Thank you very much, Vanessa, for this introduction. And can you hear me now? You can
Yes,
hear me? Yep. Okay, very well. Thank you very much for the introduction, and thanks for the kind invitation for me to participate in this meeting. Thanks to my dear friend Vishali Gupta, and to all of you, my friends from India. It's been always a pleasure to collaborate in your sessions and to learn from you. I'm always learning something. So I just want to show here very briefly my financial disclosures, none of them relevant to this talk. So I think we are all aware that uveitis in children is less of a frequency, in terms less significant in children in terms of the numbers we see, less than 10% of all cases usually, and the frequency will increase with the age of the child. The important thing to note is the frequency of the various forms, the diagnosis, and the complications will be different between children and adults. And we have to take into account geographic variations. This is just two papers for quite some time ago, but just to show you essentially that you had, amongst all the complications reported, cataract really coming up as the most frequent complication associated with uveitis in this pediatric group. We know that the patients with JIA, which we consider the different etiologies, are the highest risk of complications. And they vary: cataract, synechia, bent keratopathy, glaucoma, many things can happen. Even macular edema can happen in JIA, usually in more advanced disease. But this is more common in the intermediate uveitis form. The presence of complications when you see the child at the first time is already an indication of the risk of developing other complications. So it's an indication disease is severe, has not been diagnosed and not being treated, and many times these patients get referred quite late for assessment. The cataract will happen in 2/3 of the patients in the pediatric population and is related to many factors. It's the inflammation, prior procedures, prolonged treatment of steroids, and there's several reasons why we need to remove the cataract. Visual impairment, we want to prevent amblyopia, and adequately monitoring their disease. The challenge is related to the extraction of cataract. So technically, the many challenges you can see there, and we know that cataract tends to occur early in the course of the disease, especially if the patients are very young and the disease is aggressive. The cataract can appear quite early, quite soon. And the technical issues, clearly for SUMFIC, nothing is difficult, but for lots of normal surgeons, there are many obstacles here to get a good outcome. And one big question, which is the key point of this presentation, is related to the implantation of lenses in this eye. So take into account all these factors: the etiology of the disease, the age of the patient, we're going to talk about a bit later on, the grade of inflammation, the status of the eye preoperatively, the presence of treatment, the kind of treatment the patient is receiving, and of course, it's important to age and amblyopia are connected in terms of decisions to operate. JIA is likely to have a more complicated post-surgical course, and it's important when we're going to talk about later on some data published to feel that this could be a factor, a reason for bias when surgeons make decisions about lenses in the eye. In JIA, many times the patients are, especially younger patients, are the ones that you worry more, and they already have many times inflammatory sequelae in the eye and persistent inflammation. So these are all factors which are complicating even more the outcome in patients with this kind of uveitis. So the early reports related to the use of lenses in pediatric population indicated a poor visual outcome. There was a high rate of complications, especially those related to persistent inflammation, membranes, edema, and eventually pressure-related problems. And there were certainly challenges in the surgical technique, which would then even increase even more this inflammatory response related to the procedure and the presence of the implant in the eye. And you can see here an example of what happens post-operatively in some of these patients with implants in the eye. So what has changed since those reports? So the Iol design has changed. The materials the IOLs are made of have been assessed, and better choices have been made. The surgical techniques with the small corneal incisions have also helped reduce the trauma to the eye. But importantly is the introduction of better ways of controlling inflammation prior to the operation and actually in the post-operative period as well. This is a paper that we published a few years ago now, in which exactly we were dealing with this controversies in intraocular lens implantation. And in all the points that we all think about, there is a pre-existing problem, which means that the blood aqueous barrier has been compromised. With the post-operative period, this barrier was even more compromised with the presence of fibrin and, of course, all the sequelae that came following inflammation. The anti-inflammatory therapy has also improved. So in recent years, we have introduced better ways of treating the patients and better strategies for early intervention and more tight control of inflammation, which has a significant role in the decisions about surgery and lenses especially. These are some of the strategies we use. Sung-Fik in her talk already mentioned some of these different ways of addressing, and we can see from the data that you have in your own country, you don't find it to be very different. But again, I mentioned the issue of using devices in the eye, requiring a 2-week pre-op period to guarantee the best level of protection. The surgical technique has also improved, so less manipulation, better control of what happens in the eye. Sometimes doing this primary posterior capsulorhexis, the patients are very young. Some degree of a partial vitrectomy with anterior vitrectomy can be done as well to try to reduce the potential involvement of the vitreous and the creation of the cyclitic membranes. I mentioned the IOL materials already. We know that the acrylic hydrophobic lenses have a better biocompatibility, and we know that the silicone lenses are the ones associated with more problems related to the capsule. The procedure in terms of the lens itself, we're not going to go into that. You've seen already several wonderful demonstrations of how the technique works. But the important thing is, if you are considering a lens, consider hydrophobic acrylic lenses, but do not consider the use of multifocal or toric lenses in these patients. And sometimes, again, you may resort to still an option for some patients of the partial lensectomy, vitrectomy. So these are some examples of what you can be confronted with preoperatively. These are very simple cases, actually, and Sung-Fik illustrated very clearly how to deal with them. The small pupils, you have the option of the iris hooks, you have the options of the rings, and then you traumatize left the iris, you end up with a nice round pupil, and of course, is an important step, doing that all intraoperatively very well. When you come to the complications, the post-operative complications that can come from inflammation, secondary cataract, glaucoma, macular edema, the lens dislocating, retinal detachments, hypotony, and of course, we want to prevent amblyopia. We want to be able to reestablish good visual stimulation of the eye. So this is what we want to avoid. You don't want to see this kind of scenarios because these are disasters, so lenses that were put in the eye without proper assessment of the situation, resulting in this very bad outcome. Other examples of situations when the presence of the lens associated with complications that may affect, and many times will, the visual acuity of the patient. So these are other examples here to show you that. So when is the lens not indicated? So if you have an active uveitis despite maximum medical therapy, if you have a very young child, you have the discussed issue about bilateral disease and lateral disease in a moment. If the eye is hypotenuse, if there's rubeosis, and the other eye has already had surgery with an intraocular lens induced with complications. This is a review article that I'm going to mention here because it has a systematic review with meta-analysis, and it shows about 10 studies summarizing the data of 202 patients. These are all randomized studies comparing groups, the data coming from retrospective chart review. What I want to mention here, these are the studies listed here. You can see that predominantly, by far, JIA is the largest group, is the most common reason for cataract surgery in all these studies reported. And across 10 studies, this is specifically focusing on the intraocular lens scenario. A total of 288 eyes underwent cataract, 166 of them had posterior chamber intraocular implantations, and 122 were left aphakic. None of the studies had significant differences in age and cataract surgery between the study groups. I'm just summarizing the findings here. So all studies essentially found that regardless of IOL implantation, there was improvement in vision, but nearly all studies significantly highlighted the need of intensive immunosuppressive therapy. So this is probably the most important point here. Unclear if they were dealing with that pre-existing regime or there's something they modified. It's not clear from the studies. And this is one important thing, the allocation to either receiving a lens or remaining aphakic across the studies, well, ended up being based on individual surgeons' estimation of whether or not that would be the best interest of the patient. In terms of other conclusions, that in terms of complications compared to aphakia, you had a higher rate of visual axial opacification with the patient receiving the implant, but you had fewer cases of hypotony. And also GA-associated uveitis is known to be an important cause, as I mentioned before. So there's an element of bias here of the surgeons knowing of that already, avoiding the use of lenses in these patients. So what we see here is that even though we had a large number of patients receiving lenses here, it's still necessary to really conduct proper randomized studies to reach these conclusions, which are based at the moment in this, the level of evidence we have is what I'm showing you now. In terms of optical rehabilitation, there's no doubt that receiving the intraocular lens is the best way. Contact lenses can be a problem for young children, can be a problem because of other abnormalities such as band keratopathy. Aphakic glasses are okay for bilateral cases, but still limited visual field. So there is a strong argument for using intraocular lens, which in terms of visual rehabilitation will give you the best alternative. Final conclusions, most important is the control of inflammation. Careful surgical technique to minimize trauma. Selected cases can receive an intraocular lens, and then you consider what lens you're going to use. And in final statement is intraocular lenses are definitely possible, but not for all patients. Thank you.